Hello, I'm Purni Manohar. I'm one of the breast oncologists at the Seattle Cancer Care Alliance. Fertility is the ability to become pregnant and conceive children. Many patients, both men and women, have serious concerns about their future fertility after a diagnosis of cancer. I am here today to help answer some of these questions and alleviate concerns you may have regarding how your treatment may impact your ability to conceive children. I will also help you explore strategies to protect and preserve fertility during your cancer treatment. First, I want to share some common misconceptions around fertility and cancer treatment. Men and women both are fearful that any and all chemotherapy will make them infertile. While chemotherapy can put you at risk for becoming infertile, much of this depends on your age and the type of therapy you receive. Patients have also expressed concerns that their options to preserve fertility are limited or inaccessible. Unfortunately, fertility often takes a back seat to the pressing issue of a new cancer diagnosis, and patients do not want to pursue fertility preservation in fear of causing delays in their cancer therapy. We actually know that early consultation with a reproductive specialist does not delay treatment and can improve a patient's chances of conceiving children in the future. A large number of patients feel that bringing up the topic of fertility may change how their doctors treat them for their cancer. I say to them, your doctors care about treating not just your cancer, but you as a person, as a human being with goals and hopes and dreams. There are over 20 million cancer survivors and even more patients living actively with cancer. The chance to bring children into their world and build a family is a meaningful experience that everyone should have. Starting up a conversation and communicating your concerns with your doctor is the first step. So let's start asking some questions. How will treatment impact my fertility? Many studies show that the impact of chemotherapy for breast cancer on fertility is strongly influenced by age. Age directly impacts a person's ability to make functional sperm or eggs. Women are most fertile in their 20s with a steady decline into their mid 30s until menopause. The type of treatment and dose is also crucial in understanding the risk of infertility after treatment. For instance, we know that chemotherapy that are classified as alkylators are the most notorious for causing infertility. The dose of chemotherapy has also been implicated, with higher, more frequent doses being more likely to cause issues with infertility. Similarly, the dose of radiation associated with infertility varies based on the location radiated. Radiation to the brain of greater than 30 grays can cause downstream effects on sperm production, whereas smaller doses of 20 gray directly to the testes can cause infertility. The bottom line is that there are nuances to the risk of infertility, and the goal is always to minimize the risk of infertility, especially if this is an important goal for you as a patient. Next, let's look at options to preserve fertility during treatment. A common misconception is that fertility preservation should only be discussed with those in the highest risk. This approach is not recommended because we cannot always reliably predict what the effect of therapy may be, regardless of the dose used, and because of the possibility of relapse, which may necessitate additional treatments that may impair production of eggs or sperm. So our ultimate goal is to discuss and offer fertility preservation to all patients with a new diagnosis of cancer. For women, the most effective process is embryo freezing and in vitro fertilization. During this process, a woman takes an injectable hormone medications for on average 8 to 14 days to allow eggs to develop in the ovary at once, often about 12 eggs in a woman for under age 35. She then comes in for monitoring ultrasounds to measure the follicles, where the eggs develop about 5 times during the process. The eggs are then collected during outpatient surgery, where the ultrasound is used to guide a needle through the upper part of the vagina and into the ovary to collect the eggs. With new techniques that allow to start fertility drugs at any time in your cycle, and even on the same day as initial consultation at the Oncofertility Center, the time to collection can be as little as 2 weeks. Other methods used are oocyte freezing, which can be particularly useful in younger patients or those without partners. Fertility preservation surgery can also be performed. There are radiation shielding techniques that can provide protection to the ovaries. Ovarian suppression medications can be used during treatment and has been shown to help protect ovarian function after completion of cancer treatment. Ovarian tissue preservation is largely still experimental, but can be especially useful in prepubertal patients who have no other options for fertility preservation. For men, sperm banking is the most common and efficient method for fertility preservation. This is a process where sperm are collected from a patient and frozen via a process called cryopreservation. Timing wise, sperm banking is recommended before any chemotherapy because even low doses can impair sperm motility and affect the quality of the frozen sperm. There are also other techniques used, testicular tissue extraction process, where tissue of the testes is removed and examined for viable sperm. Some patients may be discouraged by the fact that even that sperm counts and quality of sperm may be diminished even before therapy and limited time to obtain the optimal number of ejaculate specimens and choose to forego the process altogether. However, there are technologies that can overcome these limitations. For example, advances using intracytoplasmic sperm injection have increased the chance of successful pregnancies using bank sperm because pregnancy can be achieved with a single viable sperm, making suboptimal semen quality less of a concern. Again, testicular tissue freezing can be an option for prepubertal boys, and improvements in the sperm storage can yield successful pregnancies in sperm stored for up to 28 years. Aside from the challenges with the process, there are other concerns that patients think about. These processes are safe, even in cases where hormone stimulation is used for patients with hormone-driven cancers, such as breast cancers. With early referred to oncofertility centers or reproductive oncology specialists, the fertility preservation process can be immediately started and delays in therapy can be avoided. Admittedly, cost can be a real factor for patients, especially since many insurance companies do not cover fertility preservation. Thankfully, we have wonderful organizations dedicated to helping our patients conceive children. To name a few, Fertile Hope, Young Survival, and myoncofertility.org, they know how to navigate the system and work through insurance barriers and have saved patients over $50 million in fertility expenses. I want to end by saying that fertility preservation is possible for everyone. It starts with a conversation with your doctor and an early referral to a reproductive oncologist or oncofertility clinic. Our goals are to make your dreams a reality, even through this challenging time of a new cancer diagnosis.